Good afternoon, everyone, and welcome to your third CPTA Gen webinar 2017 spring session. Before we start, we will go over a few housekeeping issues. We initially again welcome every member of the CPTA Gen. My name is Leo Brandeo. I'm a pediatric hematologist hosting the CPTA Gen webinar educational series. We're currently using a program called GoToWebinar, and this session is being recorded and it will be available at the CPTA Gen website for 1 year. Before we begin, allow me to just go over some housekeeping details to assist in everyone's participation. First, we will do the Q&A session at the end after Dr. Bates has finished her presentation. If you would like to ask a question verbally and have a microphone in front of you, please click on the hand button found on the side of your control panel to raise your hand, and we will unmute you centrally. You can also type into the question box near the bottom of your control panel to send us a question, and I will bring the question forward at the end of the presentation to Dr. Bates' attention. A quick message for the Sick Kids team in the clinic conference room. During the Q&A session, I would kindly ask you to come to the white microphone located on the podium so that your question can be heard clearly by all participants. At the end, following the college's requirements, we will send an evaluation survey for the session, which will appear at the end of your webinar. Please take a minute to complete the form. The survey will also be sent in a follow-up email to everyone that registered by email. During the presentation, if you require any assistance in participation or have a problem, please enter your comments in the question box, or alternatively, please feel free to contact me directly at 416-813-5401. Now, without further ado, I would like to introduce the speaker to our session named Contraception and Thrombosis in Adolescents. Today we have the honor to host Dr. Shannon Bates from McMaster University, where she holds a professorship, or more specifically, the Eli Lilly Canada May Cohen Chair in Women's Health. Dr. Bates needs no introduction, but I will take the liberty of talking for a few minutes about her. She received her MD degree from McGill University in 1991 and undertook her residency in internal medicine at the University of Calgary. She followed to complete her subspecialty training in hematology, followed by a fellowship in thromboembolism and a master's degree in health research methodology, both at MEC in Hamilton. Dr. Bates joined the McMaster University faculty and is currently a professor in the Department of Medicine. She serves as a director of the Division of Hematology and Thromboembolism and the director for Hematology and Laboratory Medicine. She is also vice chair of the Royal College of Physicians and Surgeons of Canada's Area of Focus Competence Committee in Adult Thrombosis Medicine. Since 2014, she has been the associate editor for thrombosis research. She has numerous, close to 100 peer-reviewed publications. She has been invited to more than 100 presentations. She is lead author of the chapter of antithrombotic agents during pregnancy for the CHEST guidelines for the 7th, 8th, and 9th edition, as well as evidence-based practice guidelines for the chapter on diagnosis of deep vein thrombosis for the 9th edition. She's the panelist and also the chair for the obstetric-related VTE for Anticoagulation Forum and chair for the ASH upcoming panel of venous thromboembolism. So with all of these tremendous predicates, we're extremely lucky to have Dr. Bates to teach and talk about contraception and thrombosis in adolescents today. Shannon, if that's okay, the floor is yours and welcome.
Thank you very much. So hopefully I can get this all set up properly, and I may have a lot of publications, but that doesn't mean that I'm the smartest chick in the room. Okay, I think we're ready to go. So as Leo mentioned, I'm going to be speaking about contraception and thrombosis in adolescents, and it's a pleasure to do so. This slide has my relevant disclosures, and as Leo mentioned, I receive unencumbered partial salary support through an endowed chair funded in part by Eli Lilly Canada. My goals for today are to review the risks of thrombosis with various forms of hormonal contraception, and to understand the thromboembolic risks, or help you understand the thromboembolic risks of hormonal therapy in adolescents with hereditary thrombophilia and or a family history of venous thromboembolism. So this slide just presents a typical case that might be referred to your clinic. So this is a 17-year-old female who originally presented for a gynecologic visit to her family physician because she had some concerns about vaginal discharge. And during the course of your or the family physician's history, she reveals that she's sexually active. She's had 3 sexual partners and uses condoms inconsistently. She has regular periods, and her last menstrual cycle was 1 week ago. On further questioning, she reveals that her mother, who is now 39 years of age, was recently diagnosed with a blood clot. She's not sure why this occurred, but knows that the clot was in her leg. A pregnancy test performed in the family physician's office today was fortunately negative. So there are some major challenges with this case. The first is obviously that the patient needs to be on an effective method of birth control. And secondly, the question arises, given her family history, should she have thrombophilia testing? And thirdly, how do you weigh the risks and balances of contraception in this setting? And it's the latter 2 questions that really lead her to be referred to your clinic. So let's just start with some basic information to make sure that we're all on the same page. So this slide presents the average annual age-specific risk of venous thromboembolism. And as you can see, the absolute risk for venous thromboembolism, that is deep vein thrombosis and pulmonary embolism, increases with age. And it increases from approximately 1 per 100,000 annually when you're less than 20 to about 1 in 100 annually when you're more than 80 years of age. So age is actually one of the most important risk factors for venous thromboembolism that we have. As was noted on the previous slide, venous thromboembolism is actually quite common in adults, and that's the population I treat, and it occurs less commonly in children and adolescents. In recent years, there have been a number of epidemiologic studies in the pediatric population that have examined venous thromboembolism. And some of these are summarized on this slide. And one of the messages from many of these studies is that amongst the pediatric population, adolescents appear to be at a higher risk of developing venous thromboembolism. And if we take the entire pediatric population, that is that entire group of, say, less than 20 years of age that I showed on the original slide, it appears that newborns and adolescents are at the greatest risk of developing venous thromboembolism. And that bimodal distribution of venous thromboembolic risk is nicely shown with the data from the Canadian Childhood Thrombophilia Registry. On this slide, we have the cumulative risk of venous thromboembolism as a function of age and thrombophilia status. So again, you can see that the incidence or prevalence of thrombosis in the normal population is strongly age dependent. As we get older, it's more likely that we've developed venous thromboembolism, and that's because first, our annual risk increases with age, but secondly, we've had more chance to accumulate venous thromboembolic events. As you can also see on this slide, the age-dependent risk of venous thromboembolism is also impacted by the presence of a thrombophilia. So as you can see, those carrying a hypercoagulable state have a higher risk of venous thromboembolism at all ages than those without a thrombophilia. Thrombophilias, as you know, are hereditary and acquired biochemical states that are associated with an increased risk of venous thromboembolism. And they're heterogeneous in terms of both the frequency with which they occur in the normal population and the strength of their association with thrombosis. In general, we can divide the hereditary thrombophilias into two groups. Group 1 is the inhibitor deficiency, so these would include antithrombin, protein C, and protein S deficiencies. And the other group of abnormalities would be those in which there's a gain of function. For example, the factor V Leiden mutation, in which there's resistance to activated protein C, or the prothrombin gene mutation, in which there's an associated increased level of prothrombin. If we look at the properties of these two groups of hereditary thrombophilias, they're quite different. The inhibitor deficiencies, that is, the deficiencies of antithrombin, protein C, and protein S, are rare abnormalities, being present in less than 1% of the population, but they're considered strong risk factors for venous thromboembolism. In the homozygous form, they're often fatal, and the associated risk of first venous thromboembolism is approximately 0.5 to 1% per year. So in the highest risk thrombophilia, that is antithrombin deficiency, the venous thromboembolic risk by age 60 years is estimated to be greater than 50%. The gain of function abnormalities like the prothrombin gene mutation and the factor V Leiden mutation are more common, being present in 1 to 5% of the population in their heterozygous state, but fortunately they're rather weak factors for venous thromboembolism. They're not lethal in the homozygous state, and for those who are heterozygous, the likelihood of developing venous thromboembolism by age 60 years is less than 10%. So most individuals who are heterozygous for the factor V Leiden or prothrombin gene mutation will never develop a venous thromboembolic complication. I think we all realize that combined hormonal contraceptives are an effective form of birth control when we use them properly. And they also can provide relief from dysmenorrhea, premenstrual syndrome, and menorrhagia, and reduce the risk long-term of ovarian and endometrial cancer. However, all of those benefits come with a cost, and we know that the use of combination oral contraceptives increase the risk of venous thromboembolism. So in this slide, we have the results of a network meta-analysis examining the risk of venous thrombosis per combined oral contraceptive in healthy women, and analyzing not only the dose of estrogen, but also the generation of progestin used. And a network meta-analysis allows evidence from both direct and indirect comparisons to be summarized in a weighted average for all possible combinations to be presented. And that's important because obviously all of the different forms of contraceptives have not been compared one to another. So in this network meta-analysis, they used 26 studies from 25 articles. There were 9 cohort studies, 3 nested control studies, and 14 case control studies. 2 of those studies reported the absolute risk of venous thrombosis in non-users, and that was 1.9 and 3.7 per 10,000 patient years, so remarkably low. Based on the data from 15 studies that included a non-user group, the overall use of combined oral contraceptives was found to increase the risk of venous thrombosis approximately 4-fold. So the relative risk was 3.5 with 95% confidence intervals extending from 2.9 to 4.3. 14 studies provided data per type of oral contraceptive, and all of the preparations were associated with more than a 2-fold increased risk of venous thrombosis compared with non-use. The lowest risk was seen in users of either the 20 or 30 microgram of ethinyl estradiol combined with levonorgestrel. So that's the LNG on this slide, and on the bottom where it says 20 or 30 in association with that abbreviation. So that's over on the left side of the slide. An estrogen dose effect was observed for levonorgestrel, so you can see that when you get up to 50 micrograms, the risk of venous thrombosis goes up, as well as for gestodine and for desogestrel. And the higher doses there obviously were associated with a higher risk of thrombosis. The relative risk of venous thrombosis for combined oral contraceptives with 30 to 35 micrograms of ethinyl estradiol and gestodine, desogestrel, cyproterone acetate, and drospirenone were all similar within that group, but about 50 to 80% higher than for combined oral contraceptives with a similar dose of estrogen and levonorgestrel. So it appears that the risk of thrombosis depends both on the dose of estrogen and on the type of progestin that's used. So that's useful information, but let's look at it a different way. Let's look at it in terms of absolute risk. So in this slide, we have data from a review that was initiated in February of 2013 by the European Medicine Agencies, and it provides estimates of absolute risk for younger women taking various combined hormonal contraceptives. So first off, you'll see at the top that for non-users, the estimated risk of venous thromboembolism per year was 2 per 10,000. And then you can see below absolute risk for the different categories of combined oral contraceptives. And what strikes you at first is that all of these risks are remarkably small, but they do vary according to content of the combined oral contraceptive. So this review concluded, much similarly to what we just discussed, that the risk for the drospirenone containing products is higher than for the levonorgestrel products and may be similar to those risks for contraceptives containing gestodine and desogestrel. The risks for cyproterone acetate weren't specifically studied in this review, but are probably similar to that group as well, with a risk of 9 to 12 per 10,000. And you can see that the risks for the vaginal ring and transdermal estrogens are in the same ballpark. So again, your lowest risk contraceptives are probably those with 20 to 30 micrograms of estrogen and a levonorgestrel-based progestin. It's important to place these risks in the context of pregnancy because, of course, that's what combined oral contraceptives are trying to prevent. And you can see that the risks of venous thromboembolism, both antepartum and postpartum, are higher than with combined oral contraceptives. So prescribing an ineffective form of contraception may well expose your patient to a higher risk of venous thromboembolism. So oftentimes we're asked, are progestin-only contraceptives safe or absolutely safe when we're trying to avoid the risks associated with combined oral contraceptives? And surprisingly, given that we know that the progestins in combined oral contraceptives are an important risk factor for the development of venous thromboembolism, we have very limited data on the association between progestin-only contraceptives and thrombosis. So the progestin-only contraceptives that are available include those in the injectable form, so that's Depo-Provera, in the implantable form, so Implanon or Explanon, and the intrauterine device, the Mirena, and as well there's a progestin-only pill. And we generally think that the progestin-only, or it's generally thought that the progestin-only contraceptives pose very little risk of thrombosis, and oftentimes they're recommended with very little thought, actually, for women at high risk. The results on this slide suggest that we probably need a little bit of a more nuanced view. So here you have the results of 3 studies. The first study by Mantha is a meta-analysis of 8 observational studies. And what you can see is that yes, overall, for all progestin-only containing contraceptives, it did not appear that there was a significant increase in the risk of venous thromboembolism. The relative risk was 1.03 with 95% confidence intervals going from 0.76 to 1.39. However, if you start to tease apart the different progestin-only options, you see that there's a difference. So it doesn't appear, at least in this systematic review and meta-analysis, that the progestin-only pill or the levonorgestrel intrauterine device were associated with an increased risk of venous thromboembolism. But what was surprising in this systematic review was that the injectable progestin, most commonly Depo-Provera, was associated with a 2 to 3-fold increase in the risk of venous thromboembolism. So it may be slightly lower than what you see with combined oral contraceptives, but you have to notice that the upper bound of the 95% confidence interval crosses the same risk that you would see with combined oral contraceptives. And 2 subsequent studies confirmed the data that we saw in the MANTHA study. So first off, Bergendahl published data from a Swedish case control study in 2014. And again, he showed in his database that the injectable progestins were associated with about a 2-fold increase in the risk of venous thromboembolism. Data from 4 Danish registries encompassing over 1.5 million non-pregnant women confirmed that the levonorgestrel intrauterine device or the Mirena intrauterine device does not appear to be associated with an increased risk of venous thromboembolism. So the take-home message from this slide is that when you're counseling patients, the progestin-only pill and the Mirena or levonorgestrel intrauterine device don't appear to be associated with an increased risk of venous thromboembolism, but Depo-Provera or injectable progestins do. So when you have a patient in front of you, how do you decide what to use? And guideline documents are a good place to start, and there are several out there, and I've listed some on this slide. The one I'm going to focus on is the U.S. medical eligibility criteria for contraceptive use. And these criteria are a Center for Disease Control adaptation from the WHO medical eligibility criteria, and they're endorsed by the American Congress of Obstetricians and Gynecologists. And what these criteria do is they provide guidance on the safety of various contraceptive methods for patients with specific characteristics and medical conditions. So this is an example of a table that you might see in the publication of the U.S. medical eligibility criteria. And the most recent set of recommendations were updated and published in 2016. And what this publication does is it evaluates and summarizes the risks and benefits for various forms of contraception, for various health conditions, and it uses a category or a criterion ranking. And so where you see a 1, that's a condition for which there is no restriction on the use of the contraceptive method. So you should feel free to prescribe that contraceptive method. If you see a 2, that means that is a condition for which the advantages of the proposed contraceptive method generally outweigh any theoretical or proven risks. A 3 is a condition for which the theoretical or proven risks usually outweigh the advantages of using the method, so you need to use caution here. And 4 is a condition that represents an unacceptable health risk for the contraceptive method that is used. And of course, the conditions we're interested in include a history of venous thromboembolism, underlying thrombophilia, and a family history of venous thromboembolism. So let's look at a little bit more detail at those. So let's go back to venous thromboembolism risk and progesterones or progestins. And as we discussed, our read, or more precisely my read of the literature, suggests that the progestin-only contraceptive pill and the levonorgestrel intrauterine device are likely quite safe options, and that injectable forms of progesterone may need a little bit more caution, i.e. they may be associated with an increased risk of venous thromboembolism that might approach the risk seen with combined oral contraceptives. As you can see, in these medical eligibility criteria, prior history of venous thromboembolism on anticoagulant therapy, and known thrombophilia, as well as a family history of venous thromboembolism, for all of those, the committee judged that the benefits of all of the categories of progesterone-only contraceptives, so the pill, the injectable form of progesterone, and the levonorgestrel, were likely safe, and at a minimum, the advantages generally outweigh any theoretical or proven risks. However, in all of these settings, as you can see on the left, the combined oral contraceptives are thought usually the risks to outweigh the benefits, and in some instances to be contraindicated. So this is their view of the literature. I would just suggest that you exercise a little bit of caution in lumping together injectable progesterones with oral progesterone pills and with the levonorgestrel intrauterine device. So the next question that's often asked, in fact was asked by one of our pediatric hematology/thrombosis faculty here at McMaster to me just last week, is, are combined oral contraceptives truly contraindicated in women with venous thromboembolism who are receiving adequate anticoagulant therapy? So again, if we go to our U.S. medical eligibility criteria, you can see that the experts on this panel judged that combined contraceptives were either an unacceptable health risk or a method for which the risks generally outweigh the benefits, both for a history of venous thromboembolism, not currently on anticoagulant therapy, as well as for venous thromboembolism on established anticoagulant therapy. So that makes sense to me for someone with a history of venous thromboembolism who's not currently on anticoagulant therapy, because we know that these medications increase your risk of recurrent venous thromboembolism. But is that actually true if you're on well-established anticoagulant therapy? Theoretically, venous thromboembolic risk should be dramatically reduced while receiving therapeutic doses of anticoagulation. And we know this to be true, except perhaps in patients with cancer. So the prothrombotic effect of hormonal therapy is likely to be suppressed by therapeutic doses of anticoagulation. And it's on this basis that a 2012 clinical guideline was published by the scientific subcommittee of the International Society on Thrombosis and Hemostasis that suggested that hormonal therapy could be continued in selected patients with deep vein thrombosis or pulmonary embolism. For example, if they had a strong indication or a good gynecologic indication or for personal preference, as long as anticoagulant therapy is continued for the duration of hormonal therapy, and with the added caveat that I always include that anticoagulant therapy is well managed. So the patient is compliant. If they're on warfarin, you're able to maintain an INR between 2.0 and 3.0. However, until recently, we actually had no good data to support that recommendation. So what we have on this slide is the results of a subgroup analysis of the Einstein deep vein thrombosis and pulmonary embolism studies. So the Einstein studies were studies that compared initial low molecular weight heparin bridging to warfarin or rivaroxaban or Xarelto monotherapy in patients with newly diagnosed deep vein thrombosis or pulmonary embolism. And this was a randomized control open label phase 3 studies. When you combine both of these studies, there were 1,888 women who could be analyzed. And of these women, 475 were taking concomitant hormonal therapy while on anticoagulants during the course of the study. They were either remaining on it despite their venous thromboembolic event, and that was most of them, or they initiated it during the study period. And the hormonal therapy that was used during follow-up in the Einstein deep vein thrombosis and pulmonary embolism study included estrogen-only pills, progestin-only pills, combined estrogen-progestin contraceptives, and progesterone-only contraceptives. And as you can see, if we look at the part that I've highlighted, the number of events per year in women receiving hormonal therapy while on anticoagulant therapy was 7 per 188, while the number of events per patient years in those not receiving hormonal therapy was 38 per 811 patient years. And what the authors calculated is something called an incidence density, which is an incident rate during the time period at risk. And what you can see is that the incidence density is similar in patients receiving anticoagulant therapy who were either not receiving hormonal therapy, so 4.7% per year, or receiving hormonal therapy at 3.7% per year. And after adjusting for age, prior hormonal therapy, assigned anticoagulant treatment, and cancer at baseline, the hazard ratio for recurrent venous thromboembolism on hormonal therapy while receiving anticoagulant therapy was 0.56, with 95% confidence intervals that are reasonably wide given the small number of events extending from 0.23 to 1.39. What was also interesting, if you proceed towards the right side of the slide, is that there was no difference in incidence density whether you were receiving estrogen-containing therapy or progesterone-only containing therapy. And if you proceed downward on the slide, whether you were randomized to rivaroxaban or whether you were randomized to enoxaparin bridging to warfarin. So this suggests that if you have a patient who truly desires to continue hormonal therapy after being diagnosed with venous thromboembolism, this is acceptable within the bounds of our understanding of the literature. But the caveat is that their anticoagulant therapy needs to be well managed because, again, these patients were in a study setting. And as we know from other studies, patients in a study setting tend to have better managed anticoagulants and tend to be more compliant with treatment than those who are not in that setting. So lastly, is an inherited thrombophilia truly an absolute contraindication to combined oral contraceptives? So again, let's go back to those CDC US medical eligibility criteria. And what they say is that yes, for combined contraceptives, a known thrombophilia is a condition that represents an unacceptable health risk, but that may not be the case if you have a family history of venous thromboembolic disease only. So we perform thrombophilia testing for a variety of reasons, not all of which are valid because we're doctors and we like to order tests. So sometimes we perform thrombophilia testing because the patient wants an explanation for their thrombosis. That's probably less helpful than we think. We may perform testing to change patient management. So in symptomatic patients, it's been suggested that maybe you would perform thrombophilia testing to determine duration of anticoagulant therapy. But what we know is that thrombophilias generally are not strong independent risk factors for recurrence outside of the knowledge of the setting in which somebody's thrombosis occurred. Some have suggested you could perform thrombophilia testing to institute prophylaxis to prevent recurrent pregnancy complications. A number of studies have really shown that hereditary thrombophilias probably don't play a role here, so you would only be testing for antiphospholipid antibodies. So if we stick to asymptomatic patients, i.e. family members, you could institute thrombophilia testing to modify the risk of a first venous thromboembolic event, that is to prevent venous thromboembolism. And what in the settings and the instance that we just discussed was to avoid known predispositions. So to avoid oral contraceptive therapy when thrombophilia testing is positive. So as we've discussed, combined oral contraceptives are associated with about a 4-fold increase in the risk of venous thromboembolism. And many physicians perform thrombophilia testing in young women with a family history of thrombosis with a view to deferring combined oral contraceptives in those with a positive result. And as you've just seen, many guidelines regard the presence of an inherited thrombophilia as an absolute contraindication to combined oral contraceptive therapy. But is that really supported by the latest data? So on this slide, we have the results of a systematic review and meta-analysis that examined the risk of venous thromboembolism in thrombophilic users of combined oral contraceptives. And the authors identified 12 case control studies and 3 cohort studies. And we're going to consider those 2 categories of studies separately. So from the case control studies, they divided patients into those with weak thrombophilias, so heterozygosity for the factor V Leiden mutation or prothrombin mutation, and then those with more severe thrombophilias, so those would be people with antithrombin, protein C or protein S deficiency, or homozygosity for the factor V Leiden or prothrombin gene mutation or combined thrombophilia. On this slide, we have the results for case control studies examining the risk of venous thromboembolism in those with a mild thrombophilia. And what you can see is that the authors determined that these mild thrombophilias increase the risk of venous thromboembolism about 6-fold. So the odds ratio was 5.8, or the risk ratio was 5.89, with fairly tight 95% confidence intervals extending from 4.21 to 8.23. There were far fewer case control studies that examined the risk in those with the so-called severe thrombophilia. And interesting, what they found is that the risk ratio was almost the same, so 7.15. But what you'll notice is that the upper bound of the 95% confidence interval extends quite far up to 17.45. So we don't have as much confidence in that risk ratio as we do for the lower risk thrombophilias. But really what we're interested in when we're thinking about counseling patients or when we're trying to make decisions are absolute risks. That's what we really need to make informed decisions. So on this slide, I've summarized some of the absolute risks for women with and without a family history, and for women who do and do not carry a thrombophilia. So for a population of about age 20, so those who are a little bit younger might have a slightly lower risk. We know that the baseline risk of venous thromboembolism is 1 per 10,000 per year. And we've already said that the birth control pill increases that risk fourfold. So that would be 4 per 10,000 per year, or 0.04% per year. A number of studies have shown that a positive family history, regardless of the presence or absence of a thrombophilia, increases the risk of venous thromboembolism at least twofold. So that would bump up our risk to 0.08 per 100 combined oral contraceptive years, or about 0.8% per year. And then what I have below are data drawn from the 3 cohort studies, so the 3 family cohort studies that were also included in that meta-analysis that I just described. And as you can see, in women with a positive family history of venous thromboembolism who are found to be antithrombin protein C or protein S deficient, and that's the thrombophilia in the family, if they're on combined oral contraceptives, their annual risk of venous thromboembolism ranges between 4.3 and 4.6% per year, depending on the study that you look at. So that risk is clearly high enough that it may be worthwhile to test women from those families in order to avoid prescribing combined oral contraceptives to those that are antithrombin protein C or protein S deficient. But what's interesting is that if you look at the non-deficient members of that family, so women who come from a family with antithrombin protein C or protein S deficiency but who test negative for the thrombophilia, their risk ranges between 0.48 and 0.7% per year. So that's still reasonably low, but it's not the same as in those who have only a positive family history, and certainly not the same as in those who have no family history. So when you're undertaking thrombophilia testing in these families, you have to be very careful that when you're counseling the non-deficient members of the family as to whether or not they can use contraceptives, that you're not actually making a blanket statement that their risk of venous thromboembolism is the same as in the general population, because it's actually not. If we look at women from families with the factor V Leiden or prothrombin gene mutation, in non-deficient members, the risk of venous thromboembolism on combined oral contraceptives is 0.19% per year. So that's actually quite low again, but not as low as in the general population. For those who happen to be homozygous for one of those mutations or have a combined thrombophilia, the risk of venous thromboembolism approaches 0.9% per year, whereas if you're heterozygous, it's about half that at about 0.5% per year. So one of the things that this slide makes clear to me is that it's not all that clear that one of these other thrombophilias, the factor V Leiden or prothrombin gene mutation, is an absolute contraindication to combined oral contraceptive use, as is outlined in those medical eligibility criteria. And given that, it's not clear that thrombophilia testing is actually going to make a big difference in your management of these families. And I think the important thing is to have a discussion with patients from those families before you perform thrombophilia testing to ascertain what their risk threshold for venous thromboembolism they're willing to accept in order to use the contraceptive pill. Because if they set their risk threshold at 1% per year, thrombophilia testing is not going to make a difference. Similarly, if they set their risk threshold as anything above the general population, thrombophilia testing is not going to make a difference again. This slide approaches the same problem in a different way. So on this slide, we have data from a retrospective family cohort study in which the authors used absolute risks of venous thromboembolism during combined oral contraceptive use and during pregnancy in the postpartum period in relatives of symptomatic probands with the factor V Leiden or prothrombin gene mutations to look at the risk of venous thromboembolism with each form of contraception if you include not only venous thromboembolism attributable to that form of contraception, but also venous thromboembolism attributable to contraceptive failure with subsequent pregnancy and thrombosis developing through pregnancy. So let's just work our way through the first column of this slide. So in this study, the investigators found that asymptomatic members of families carrying factor V Leiden or the prothrombin gene mutation who were heterozygous for one of those abnormalities had a risk of venous thromboembolism of about 0.55% per year, or 0.55 per 100 patient years. On the combined oral contraceptive, there's a failure rate of about 0.2 per 100 patient years. That means you have 200 pregnancies per 100,000 patient years. And if the risk of venous thromboembolism, both antepartum and postpartum, in individuals who are heterozygous for one of these abnormalities and has a family history of venous thromboembolism is approximately 3%, that means you get an additional 6 venous thromboembolism cases per 100,000. And so that means your total number of VTE per 100,000 is 556. The levonorgestrel intrauterine device, copper intrauterine device, and condom obviously don't increase your risk of venous thromboembolism, but they are associated with a slightly higher risk in the case of the levonorgestrel IUD and a much higher risk in the case of condoms of unintended pregnancies. And interestingly, if you add those additional VTE cases resulting from unintended pregnancies to VTE directly attributable to the type of contraceptive you use, it becomes very clear that advising condoms is not always the best advice, because someone who's advised to use a condom and doesn't use it properly and or has the misfortune of becoming pregnant actually probably has a higher risk of developing venous thromboembolism than someone who you would have just prescribed combined oral contraceptives to in the first place. So in asymptomatic patients, thrombophilia testing is really probably only helpful if there's a family member with a known abnormality that tracks that VTE history. We don't have any good data showing that testing benefits family members, so no studies have actually been able to tease that out. What we know and what I've discussed is that a family history of venous thromboembolism increases the risk of venous thrombosis twofold, even if someone tests negative for a thrombophilia. And we've seen that the baseline risk of VTE on combined oral contraceptives is higher in unaffected family members than you might expect. So those people need to be appropriately counseled as to their risk, and they need to know about prophylaxis and high-risk situations and signs and symptoms of venous thromboembolism. Where thrombophilia testing may affect patient management is really for patients who have high-risk thrombophilia or for those with common inherited thrombophilia who have a low risk threshold for accepting risks of venous thromboembolism. There, perhaps doing the testing might help make the decision a little bit easier. But obviously, before you perform thrombophilia testing, you need to counsel patients about potential drawbacks and limitations of thrombophilia testing, including potential impact on obtaining insurance. And obviously, the results of thrombophilia testing should always be interpreted by an experienced physician. So as we approach the situation of adolescents or even adult patients who have risk factors for venous thromboembolism but need some type of contraception, it's important that we perform an individualized risk stratification. So we need to take into account the type of thrombophilia the patient has, the presence or absence of a family history, and additional risk factors. And we need to counsel the patient regarding venous thromboembolism and other risks associated with contraceptive methods, but also risks, including pregnancy, associated with not using appropriate contraceptives. And it's important that we use absolute risk because that provides us with the best information. And we need to involve the patient in this type of informed decision-making because they're the ones that live with the consequences. We need to consider their preferences and their risk thresholds, the likelihood of their adherence to a form of contraception, and obviously we should try and use the lowest risk options when possible. And in a couple of slides, I've just emphasized over and over again using absolute risk. And that's particularly important because how we present risk affects how our patients interpret risk. So on this slide, I have the main results of the study that evaluated patients' knowledge on the risks of venous thromboembolism associated with combined oral contraceptives, and their perception of this risk when the risks were presented as a relative risk, so that's an RR, an absolute risk, an ABR, or an attributable risk. And so this was a small cross-sectional study of 159 users or potential users of combined oral contraceptives, and the participants all answered a self-administered questionnaire in which the risk of venous thromboembolism associated with combined oral contraceptives were presented those three different ways. And then patients were asked to agree or disagree with a statement of concern regarding the risk of thrombosis associated with contraceptives. And so most of the women, about 68%, were concerned about the risk of venous thromboembolism when the results were presented as a relative risk, i.e. combined oral contraceptives increase your risk of thrombosis at least fourfold. Conversely, they showed much lower concern when that data was appropriately presented with absolute risks or attributable risks. So the take-home message is to think a little bit about how you're presenting these risks to your patients when you're performing their counseling. And then the last part of your patient-centered approach to counseling is to make sure that all of your patients, regardless of whether they wind up on hormonal contraceptives, are counseled about the signs and symptoms of venous thromboembolism and arterial thromboembolism, and you need to go into a bit of detail with that and provide them with some written information if you have that available. And then you need to remind them about the need for thrombosis prophylaxis in situations associated with an increased risk of venous thromboembolism. And I always remind them to remind their physicians about this, because as physicians, we're notorious for forgetting about prophylaxis. So pretty much any time, say to a patient, somebody does something to you, gives you a new medication, admits you to hospital, or thinks about surgery, you need to ask whether this will increase your risk of venous thromboembolism and if there's something you should be doing about it. So for your patient that we talked about at the beginning, should thrombophilia testing be performed? Probably, but ideally it would be helpful to have the mother undergo thrombophilia testing first, because that'll help guide you. Because if the mother doesn't carry a thrombophilia, then there's no point testing the daughter. The mother carries a particular thrombophilia, then you can gear your counseling with respect to thrombophilia testing to that particular thrombophilia, and then if you decide to proceed with testing, you'll have some good numbers as to risks and how you approach your patient. Thank you very much.
Thank you very much, Shannon, for this very clear presentation on contraception and thrombosis associated risks. Let me see if on the panel we have any hands being raised or questions. And while we wait, I'll take the liberty of maybe unmuting one microphone at a time to maybe ask if the specific site has a question. I'll start with Ms. Brenda Gallinger's site by opening the mic there. I'm not sure the location, Brenda, and so are there any questions from the center with the microphone under the name Brenda Gallinger? No questions there. Let me move to, I think, now I have Dr. Wu, Selena Wu. Is there any questions from you, Dr. Wu? No questions there. Let me move to the next mic under Ms. Cynthia Talon. Any questions from that site? No questions, Shannon. I'll open the mic now. From Irene Papaspiro's site. This is at McGill.
Hi. Yeah, hi, it's Christine Savapathy.
Hi, Christine, welcome.
Thanks, Leo. Great talk. I just had a question about your heterozygosity for factor V Leiden and OCP.
Right.
You know, I was previously taught, and there's some literature that talks about a synergistic effect between the two and having a higher relative risk when you put the two together, but you seem to combine the prothrombin and the factor V agent.
Right, and I mean, and that's a limitation of the literature, right? So I think, you know, in order to get relatively robust estimates without really wide 95% confidence intervals, we do wind up oftentimes combining that data. But I think, you know, what we've seen, at least in the pregnancy data, is that the risks are actually not all that different for the two types of thrombophilia, and that may hold true once we start looking at, instead of case control studies, which is what those initial studies were based on, if we start looking at family studies, which provide us with the better data, I suspect we'll find that the absolute risk estimates are probably not all that different. And as you can see, they're quite low. And those risks are mostly being driven by factor V Leiden data rather than the prothrombin gene data, which, if anything, is probably going to be lower again.
Yeah. Okay, thank you.
You're welcome.
Thank you, Shannon. Let me move to another site. I will open now to, I think, Stollery Children's Hospital. We have Mary Bowman and with a mic sign. I'm opening it to Mary. I don't know if you can hear us. Mary, any questions from Edmonton? No questions. Let me now come to Ontario, and I'll open the mic to the floor to Sick Kids in Toronto. Do we have any questions here at Sick Kids in Toronto? No questions from the floor, Shannon. Let me. I think there's a comment from Calgary congratulating you on a very good talk, which we echo.
Thank you very much.
Let me see. I think there was someone from Sherbrooke, Quebec. Dr. Brossard, is there any question from Dr. Brossard from Sherbrooke? No, no questions. You were clear, very clear, Shannon.
Or I scared them.
On your message. Let me see. I have a final mics to try to open. Let's see if no. Shannon, you have a lot, obviously tremendous clinical experience with dealing with adolescents and non-adolescents. In terms of adolescent preferences, when you've been after counseling for so many years, do you think, are there additional comments that relates to particular characteristics of IUD in certain populations and concerns that should be raised versus the IUDs nowadays are so good that those concerns no longer exist in terms of infections and things of that sort? Are there any further comments that come along or in addition to thromboembolism that dissuade you from using one agent versus another in specific populations?
Yeah, so again, you know, one of my disclosures should have been I'm predominantly an adult hematologist, so I don't see very many adolescents. And you're right, there is always a little bit of a concern about using an IUD in the adolescent population, though I think that varies from gynecologist to gynecologist. So I think some are more comfortable with it than others. I think the risks of other adverse side effects with IUDs it's never zero, but I think it's pretty low and probably similar to the risk of adverse effects of other types on combined oral contraceptives or on progestin-only therapy. My gut feeling is that every patient is different. So some patients, depending on what their family members have experienced, are not willing to accept any risk of thrombosis. So we'll take the lowest common denominator, regardless of, you know, effectiveness or other adverse effects. So, you know, if you had a mother who suffered a really serious thromboembolic event, you may decide that I'm never going to take the pill, even if it turns out I don't have a thrombophilia and my mom has factor V Leiden, so my risk of VTE on the pill is 0.2% per year, whereas there are other women who maybe their family history isn't as scary or they process information differently, who are much more comfortable taking small risks of venous thromboembolism in order to have really what is the most convenient and the best form of contraception if you can do it, which is a combined oral contraceptive. So that's why I really think individualized counseling and a good discussion about values and preferences and finding out what people's risk thresholds for VTE are in their head and what their other important concerns are is just so important because, you know, every patient is completely different. And the choice they're going to make, you often won't know until the end of the interview, until you work through things together. And these conversations take a long time, right? You're never going to get rich seeing these type of patients because that's a good 30-minute conversation for a thrombosis doctor, at least even when you're experienced doing it. But I think you need to take the time to do it well because it's of so much importance to these young women.
Okay, thank you very much. And I think I don't see any additional questions, Shannon. If that's the case, I'll take the liberty of closing the floor, reminding our audience that next week on the same 3 p.m. Eastern Time spot, we're going to have Dr. Veronica Flood presenting on the changing landscape of von Willebrand disease diagnosis, reminding everybody that this will be our 4th and final CPTHN webinar of our academic year. Thank you very much, Shannon, for this enlightening and very clear explanation on a complicated topic, and we'll be seeing everybody next week. Thank you again.
Thank you very much. Bye-bye.